We'll talk about cervical arthroplasty now, and differently from every other device we use in the body, there's actually a huge amount of science behind arthroplasty, which is sort of interesting why regionally in the United States there's pushback from people who continue to say, well, it's unproven or doesn't really do good results and fusion works better. Hopefully I'll show you, why the science is so good. I consult with a whole bunch of the companies that are bringing arthroplasty designs in, so I have no vested interest in one or the other. I'll show you the 10,000-foot view and the timeline. These are the three discs that kind of call the legacy discs. These are the original cervical artificial discs that got FDA approval pre-2010. So these three guys were around for several years. Then the next batch in 2012 were the Security, that's a Globus disc, and the PCM. So slowly these studies had been percolating. These were all multi-center prospective randomized control trials that take about 5 or 6 years to incubate until they can go through the FDA and get FDA approval. 2013, LDR at that time kind of hit a home run. They had done both 1 and 2 levels concurrent studies of the MOBI-C, and they were able to get their FDA approval pretty much concurrently also for 1 and 2 level. And for a while they had the only 2-level indication. And the Kineflex, which is the one to your right, was a metal-on-metal disc that ran, interestingly, a lumbar and cervical study at the same time. And on the eve of their panel, after investing 6 years and God knows how many tens of millions of dollars, they got a call from the FDA, and they said that the FDA is taking such a black eye for metal-on-metal hips that there's no way they will approve a metal-on-metal cervical or lumbar arthroplasty device. So they said, you can take your lumps in public tomorrow, or you can withdraw your applications and go away, which is what the company chose to do. So after all these resources had been expended, literally on the eve of, that was taken out. So that's not available. And then in 2014, Medtronic got approval for the Prestige LP single-level device. Two new devices are in FDA trials right now, one of which was the M6. And in 2016, a second one, the Simplify disc, which is PEEK on ceramic, started its FDA trial, and then the Prestige 2 level was approved. So that's sort of the timeline for what's available. That's a picture of the newer one, the Simplify, which has interesting radiographic and MRI properties. It's pretty invisible. Here's looking at the timeline and a graphic view. If that resonates a little bit better for you, you can see again the two discs on the right, the M6 and the Simplify, are still in FDA trial. They are not yet FDA approved. So there are some other discs in pipelines, mostly OUS. There's nothing else in the US pipeline right now except for the Simplify and the M6. But you can see that outside the US, there are other manufacturers who are working through some prospective studies in order to hopefully gain a little toehold when they do come to the FDA to start a US study. So there's a lot of interest in cervical arthroplasty. It's a very big market. The ACDF market is huge. And as a result of all of these FDA studies, even the ones that never got commercial approval, many of them still publish their results. So there's a huge amount of peer-reviewed published data on 2-year studies, 5-year studies, and even 4 papers on 7-year outcome studies. So, there's a tremendous amount of level 1 scientific data that's been published following these very large cohorts of patients with pretty high follow-up rates out for long periods of time. So just to kind of make this into a reasonable talk, I'll just give you some highlights of outcomes, of durability of the outcome improvements. Do they maintain themselves out for years? How about reoperation rates between ACDFs, an operation that's near and dear to all of our hearts, and cervical arthroplasty? We'll talk about adjacent segment degeneration and what does level 1 research really tell us. And then I'll show you 2 of the 2-level studies and what their outcomes are. So the clinical outcomes are pretty easy to summarize. The outcomes are consistent across all these studies. So with all of these different disc designs, different technologies, different mechanics, and even different materials, the outcomes are really pretty consistent. NDI, VAS, and patient satisfaction are all almost superimposable in all these studies, as are ACDFs, which came in handy when the Labor Department in the state of Washington or Blue Cross in North Carolina said, hey, we're not paying for ACDFs for treatment of cervical radiculopathy anymore because there's no good literature, because they didn't look beyond year 2000. And they're right, in the 50 years before year 2000, we didn't really have really good literature. But fortunately, we had the control arm of these early FDA studies, and we're able to show that literature and get reversals of those decisions that show that ACDF for cervical radiculopathy is a great operation. And I'll show you the data that shows that cervical arthroplasty is at least as good, with perhaps some additional benefits in the future. In every single study, arthroplasty was not inferior to ACDF. Most of these were powered as non-inferiority studies. Some were powered as superiority studies, and in fact, in some studies, the arthroplasty is superior statistically, but in no study was it inferior to an ACDF. And the reoperation rate is like the golden child in this, that in every single study, reoperation rates are less at 2 years, 4 years, 5 years, 7 years in the arthroplasty cohorts than they are in the ACDF cohorts. This was just a study that we did looking at 4 of the early studies and their ACDF controls. And interestingly, Donna Onmes, who's the research person, head of research at TBI, realized that the NDI is the only consistent question across every single study. Every other question, even something as simple as a VAS line, is asked differently. Some are, what's the worst pain you've had today? What's the worst pain you've had in the last year? What's the worst pain you've had in the last month? So those can vary from study design to study design, but NDI is always exactly the same. So NDI is the one thing you can look at, and here you can see the hockey stick is basically superimposable. From a very high preoperative NDI, it drops down almost immediately at 6 weeks, and here in this study was maintained at 2 years, but we've again shown that at 4 years, 5 years, and 7 years, we don't lose the NDI. The patients don't start getting more impairment. They maintain the improvement they got at 6 weeks. There are a whole bunch of meta-analyses that have been done, and in levels of evidence, multi-center prospective randomized control trial is level 1, but 1B. Level 1A is a meta-analysis, which is an analysis of those multi-center trials, and several have been done of the 2-year studies. One of my favorite ones is Upadhyay's. You can see the author list. These are very well-respected researchers. These looked at the 3 legacy discs. They pooled about 1,200 patients with 24-month follow-up, and the fusion rate in the ACDF controls was really high. It was 95%. So it's not like you're going to make the artificial disc look better by having a little bit lower fusion rate. These were good, solid controls that they were comparing the patients to. So what were the results of that meta-analysis? Again, this level 1 scientific evidence. No significant differences across the TDR implants, that they all gave about the same benefit without statistical difference. That the arthroplasty patients in that pool, 1,200 patients now across all of these studies, which means each study has 15 to 20 sites and 25 to 30 surgeons and 250 to 300 patients. So we're talking about lots of patients now. Greater neurologic success rate in the arthroplasty patients, which we've always found. And we think is because we're a little more meticulous in our decompressions when we know we're going to put a motion device in than when we're just going to distract it and put a block in, and a lower reoperation rate, which consistently occurs in every single study. Well, how about the longevity of results? Do these things hold up, or are they like 2-year wonders, and then if you follow the patients long enough, they start turning to junk again? That's not the case. That the 5- and 7-year papers have shown absolute maintenance of improvement in both groups, in the arthroplasty groups and the ACDF groups, proving that if you get a patient with single-level radiculopathy who's failed conservative care and you operate on him, he is going to be better and stay better for at least the 7 years that we're following these people out. I'll show you the ProDisc 7-year outcomes data. was published. Mike Jansen was the lead author on that. That was the first of these papers where we chose to use an independent biostatistician. We didn't use the biostatistician of each company. And not that that's a dirty thing to do, because you got to remember that all that data goes to the FDA, and at their discretion, they can go through the data with their own biostatistician. And nobody knows whether they do that 100% of the time or 5% of the time, but no company wants to be caught with their pants down where their data analysis is different than what the FDA comes up with. That would be bad for the world. So not that it's a bad thing, but we instead went to an independent biostatistician. It was actually Dr. Kopchar at UW, and he agreed to be a co-author with us, and he independently reviewed all the statistics. Pretty high overall follow-up rate, about 80% for 7 years, which is, it gets increasingly hard to find patients after the 24 months. So 5-year papers are a slog to get these people back, and 7-year papers, it's really hard to get them back. So 80% is really damn good. And you can see the curves. Here's the Neck Disability Index, the NDI improvement curve, for both arthroplasty and ACDF patients. And again, they come in with significant impairment. They can't button their shirt. They're not, feeding themselves well. People have trouble when they have cervical radiculopathy. They get better. And by 6 months, they're sort of improved. And that is maintained out to 7 years with all of these data points for these patients. And if you look the same thing for VAS arm pain, patients don't come to us and say, hey, my NDI stinks. They come in because my arm hurts and it's on top of my head and I can't use it and I'm not sleeping and I haven't gotten better in 2 months with 2 Medrol dose packs and collars and all that stuff. So that's what patients respond to. That's really why there are patients, and that's how they'll gauge success. And is it successful? Unbelievably successful, right? This is the data that kind of reversed those decisions by payers who were reluctant to continue paying for surgery. We were able to show them this kind of stuff. Reoperation rates in every single study that's ever been published favor the arthroplasty cohorts. And again, these are prospective randomized studies. They're not randomized by the surgeons. They're randomized externally, not by the companies either. They all use like a third-party Ernst and whatever the accounting firm is. They're on rotating blocks of 6, which means that you never know what's coming. Your last 2 fusions could have been the end of one block, or you could be straddling a new block. So there's no way you could pre-select the athletes to get arthroplasty and the dumpy people to get fusions. It didn't happen. It was all very clean, good demographics in both groups. So these are really good, believable studies because they were randomized at the beginning. The only variable is what device they get. And in the patients who got randomly assigned to artificial disc, you can see that their reoperation rates in the ADR column are significantly less than in the ACDF column, sometimes by a factor of 3 or 4 to 1. So these are not just like small differences. In some of these papers, the differences are really high. How about the 7-year studies? I told you there are 4 7-year papers that have been published. In those 7-year studies, again, you can see the difference in reoperation rates in patients who were just randomly assigned to get an ACDF versus the exact same patient population, but randomly assigned to get an arthroplasty. Again, significantly less by 2 to 1, 3 to 1, sometimes 4 to 1. So, it comes to a point where, if your brother calls you and says he's got a herniated disc, he's not getting better, he's got radiculopathy, which should he have? If all things are equal as far as outcomes, this is pretty compelling when you can say to him, hey, in 7 years, you only have 1/3 the risk that you're going to need another operation on your spine than if you have an ACDF, which is a really good operation. So, I think this is becoming, more and more evident because it's repetitive and it's layered over and over again with different studies. People always ask, is the reoperation rate at the same level, or is it primary level, or is it adjacent level? And Rick Delamarter published a paper just looking at the reoperation rates. And you can see that in both groups, it's a little bit, it's more at the adjacent level, certainly in ACDF, than it is in arthroplasty. In arthroplasty, it's about the same reoperation rate at index level versus adjacent level. In ACDF, it's significantly greater at the adjacent level. And that number will get bigger as we start to follow these patients for longer and longer periods of time. We were kind of surprised to see a difference at 2 years. We thought it would be, probably going to be 5 or 10 years before you start seeing that big a spread. But we saw it early, and the delta continues to widen as time goes on. So those were all single institution, or actually multi-institution, but single device studies that we just kind of pooled together. At TBI, we were lucky enough to have been involved in 6 different IDE studies in cervical devices. So we flipped it around, and this is a single institution multi-device study. We said, hey, what's our reoperation rate? When you have kind of the same group of guys in one institution, that eliminates a lot of variables, but now you're looking at just 6 different devices. So we had, you can see 84 patients who had randomized in these studies to arthroplasty versus 52 in ACDF. Follow-up rates were high because these were all parts of primary IDE studies. So the follow-up rate was high, and you can see it's a minimum of 2-year follow-up way out to lots of years. And the reoperation rate, again, showed this big difference, a 2-to-1 to 3-to-1 difference in reoperation rates between the two. So no matter how many ways you kind of slice the cucumber, you keep getting, the same seeds. Adjacent segment degeneration, it was a big incentive to look at artificial disc replacement, and now we have a chance to study it in a more realistic way. If you look back at adjacent level degeneration following ACDF, the literature goes pretty far back. You can see Harry Herkowitz in 1990 saw it in about 40%. We all know Hillebrand's study, about 3% per year, followed over 10 years, became symptomatic. And a more recent study looked at it in fusion threaded anterior cages, not even with plates, showed it up to 50%. When you start looking at the global literature, 3 of these are OUS and 1 was in the US. The difference between radiographic adjacent level disease and ACDF versus arthroplasty, you can see almost a 2-to-1 difference. In Dom Korek's paper here, it's almost a 3-to-1 difference. And in 2 European, it's not as dramatic, but there's still always a difference that favors the arthroplasty patients as requiring less need for adjacent level or reoperation surgery. I think this was Dom Korek's presentation or paper in Journal of Neurosurgery Spine showing that there's more severe degeneration that occurs at the adjacent segments as you follow patients out who have had ACDFs versus arthroplasty. So even in the arthroplasty patients who develop adjacent level changes, they're not as severe. They don't go up as many grades as the patients who have an ACDF. So there is some protective effect that's suggested by motion. Other people have looked at it. Mike Heisey looked at the MOBI-C patient populations, and he's looked at superior segment versus inferior adjacent segment disease, and again showed that at 12 months to 24 months, there's been a bigger and bigger delta between the adjacent segment degeneration in patients with arthroplasty versus arthrodesis. Jeff Spivak at CSRS presented papers a couple of years apart, and this was the early paper that showed that about 78% of the patients who were in that random ACDF control group had developed adjacent segment X-ray changes judged by independent radiologists. It was all done at Medical Metrics on digitized film, so this is not surgeon biased in any way. And he compared it to the cervical arthroplasty cohorts in a randomized and in the non-randomized, which was after the FDA got all the data, they allowed us to do PRODIS-Cs in a couple hundred patients under their supervision for safety, but no longer for efficacy. But you can see there it was in the 40%, so big differences. Jeff's bigger paper, he presented at CSRS about 3 years later, and what he did is he looked at adjacent segment degeneration versus range of motion. So it was one of the first times that we actually looked at the protective effect of motion on adjacent segment disease, but in a scientific way. And we used this Kellgren-Lawrence classification. We asked the radiologists down at Medical Metrics to use this. This is a validated system. And even if radiologists don't read well, they can look at pictures. There's very high inter and intra-observer reliability in this system because it's pretty straightforward. So we had the radiologists grade the PRODIS-C patients, and they did two guys who did it. If they disagreed, they got a third guy as a referee. And here's what Jeff found, that when he divided them up by how much range of motion we were able to give, If we didn't do such a good job and the patient had between 0 and 3 degrees of motion, so that essentially they got an ACDF, they had about the same amount of progression as the ACDF patients did in the paper he presented a few years before. If they had 4 to 6 degrees of motion, their adjacent segment degeneration by this classification by independent radiologists fell, and if they had more than 7 degrees of motion, it fell again. So this is one of the first times we're able to see that there is a protective segmental effect by how much motion you do. So, kind of behooves us to, if you're going to do artificial disc replacement, do a good job. Pick your patients right, mobilize the segment well, and put in a device that'll still have them moving at 7 years, because there's a benefit to it. They'll get less adjacent level disease. So better motion will yield less radiographic adjacent level disease. And then just slice the onion a little bit more to get a little more granularity, again looking by the progression in grades. And you can see, if you look at the greater than 7 degree bar, the ones who really got a lot of motion, most of them had yellow. Most of them had no progression. I mean, much, much more than the guys who had very little motion. So, you can really help patients out by A, doing arthroplasty if they're good candidates for it, and B, doing a good job. How about two-level arthroplasty? I borrowed some of these slides from my partner, Mike Heisey. There are only 2 devices that are FDA approved for two-level right now. They're simplified disc, the one with the metal and ceramic, is in about 2/3 of the way enrolled in their 2-level FDA study. So they've still got a few more months to enrollment, and then another couple of years before they'll be approved. So there's nobody else coming behind for a few more years. So Mobi-C has their 2-level approval since 2013, and Medtronic has the Prestige LP 2-level approval since 2016. They've been pretty slow to kind of make people aware of that. So Mobi-C's kind of had the 2-level market to themselves for a while, and they've also done a very clever job of convincing the insurance companies that they should only grant approval for a device that has an FDA label for that indication. So they've stiff-armed the other guys with a 1-level approval from getting approved for 2-level surgery. So they were very, very kind of clever and proactive about that. In the Prestige study, as Medtronic studies, they enroll a lot of patients. So they were trying for superiority claims. You can see how many patients are enrolled in a multi-center prospective trial. Lots of data points is in all of these trials. And then it was finally FDA approved in 2016. And compared to ACDF, you can see it maintained the clinical outcomes, segmental motion, and was superior in most of their areas studied. The Mobi-C study design was similar, also used a lot of patients and looked at it versus a 2-level ACDF and followed the patients again for all the data points. It's the beauty of these FDA studies. Getting involved in them is not so beautiful because there's a tremendous amount of paperwork that's associated with it, but that's where we get the science. That's where we're able to say that, independent of what our belief system is, that this is really the science that medicine is founded on. Most of these studies use these composite endpoints where patients have to be successful in several different categories in order to be considered a successful patient. And at the end of the day, that's what the FDA says. Show us the % of patients who are successful in all of your sub-points in each group. If the group that got disc replacement was no worse than the group who got ACDF, then you've met your non-inferiority hypothesis. If that group is statistically better, then you've met a superiority hypothesis. But either way, depending on how you've structured the deal with the FDA, that's what passes the door to get into commercial sales. So if you look at overall study success, you can see that this is how the superiority claim gets in. You're looking at the % of patients who have met that success criteria in all those 5 subcategories. In the blue were arthroplasty patients, and in the red were fusion patients. So just follow the numbers, just track the data. It just becomes a very heavy numbers game with the FDA. And again, you can break down the components and see, the patients had to be successful in NDI, meaning a 15-point improvement from their baseline. They had to have no subsequent surgeries. Their neurologic had to be maintained or improved, and that's all aspects. It's motor, sensory, and reflex. No adverse events and no radiographic failure. So to get a patient to be successful in these categories is not so easy because they may have a meaningless you know, a 2+ bicep at 2 years when they had a 3+ before, or a 2+ down to a 1, but they're pitching for the Astros, you know. So it may not matter clinically, but that becomes a neural failure in an FDA study, which becomes a patient failure. But that's why it's controlled, because you figure you're going to put those same parameters in both groups, so those things should net out. But that's why they're not high numbers like 100%, because people are very particular about grading these patients. So, you know, the 2-level Moby study, obviously they had more trial success, and they were able to also show that there's less degeneration. And here's the difference between the 1-level and 2-level Moby study, and you can see the deltas are much better in 2-level disease. So 2-level arthroplasty is actually a better option than a 2-level ACDF than a 1-level arthroplasty to a 1-level ACDF. And the reason is I think 2-level people are in more shape. You know, 2-level people are hurting more. We know a 2-level ACDF makes them better, but there's price to pay with 2-level ACDF in loss of motion and potential for more adjacent level degeneration. So I think the 2-level patients are really more needy of arthroplasty than a single one, in my opinion. So what we find out, that looking at these large cohorts of patients, looking at lots of studies and slicing the data all the way, that there is significantly less radiographic adjacent level degeneration in the arthroplasty patients, that motion really strongly appears to protect against adjacent level progression, and particularly against severe adjacent level disease. The arthroplasty is good, and 2-level disease seems to be a better fit even than 1-level disease, which can stand on its own, I think, you know, very proudly with all the data. But the jewel of all this, again, is the reoperation rates, which in every single study are significantly improved with cervical disc replacement. So I think it's here to stay. I think, you know, that's going to be, you know, part of our future as spine surgeons and your future as spine surgeons. So, you know, again, regionally, there are places that kind of disrespect arthroplasty in general, lumbar more than cervical, but even cervical, and there's just no good science behind that attitude. So, you know, no data at all suggests that it's inferior. Strong level 1 data about degeneration and reoperation rate. And again, this is level 1B and even level 1A evidence. So, you know, it's not just a cheerleader talking to you. This is a scientist talking to you. So thank you, guys. Thank you very much, and we'll see you soon.